Good evening, my name is Aresaneuse Halaka, a third-year pharmacy candidate, and I did my journal club on sofbuspivir for previously untreated chronic hepatitis C infection. So, the objective of this trial. In the clinical studies to date, no virologic breakthrough has been observed with sofbuspivir. 2 phase 3 studies were conducted to evaluate the efficacy and safety of sofbuspivir plus ribavirin as a backbone therapy versus current standard backbone PEG interferon alpha ribavirin. Side effect profile was to be compared with each treatment arm along with hepatitis C viral load during and after study. Compare the treatment arms. Resistant testing to be performed if needed, and safety statistical analysis to be compared as well. So the trial design. The Neutrino trial was a single-group, open-label study of sofbuspivir, PEG interferon plus ribavirin in 327 patients infected with hepatitis C genotype 1, 4, 5, or 6. The FISION trial was randomized, open-label, active control study of sofbuspivir plus ribavirin in patients with hepatitis C virus genotype 2 or 3 infection. The location. The Neutrino trial was in the United States, and the FISION trial was in the United States, Australia, New Zealand, Italy, Sweden, and the Netherlands. IRB approval. Each study was approved by the Institutional Review Board or Independent Ethics Committee at the participating sites and was conducted in compliance with the Declaration of Helsinki, Good Clinical Practice Guideline, and a local regulatory requirement. Both studies were designed and conducted according to their protocols by the sponsor in collaboration with the principal investigators. Inclusion. Patients must contain a hepatitis C virus RNA of more than 100 units per ml, and patients must have a hepatitis Z virus genotype 1 through 6. Exclusion. Hepatitis Z virus RNA less than 1,000 units per ml were excluded from this study. Ages of less than 18 years old were also excluded from the study. Patients received hepatitis C virus treatment in the past could not participate in the study. So the subjects. Participants ranged in the ages of 19 through 70, consisted of males and females. Races of the people in the trial were white, black, Asians, and Hispanic. They had a range in the BMI of 17 through 56. Most of the patients in the Neutrino study had hepatitis C virus genotype 1 at 89%. Prevalence in the United States for hepatitis C virus genotype 1 is 70%. Therefore, the study concludes resembles what most people have in the U.S. The demographic and baseline clinical characteristics were balanced between the two study groups in the FISION study. A total of 20% of patients in sofbuspivir had cirrhosis, and a total of 21 of those in the PEG group had cirrhosis. 666 patients with genotype 2 or 3 were essentially screened, 527 underwent randomization, and 499 began treatment. So the primary endpoint. In the two trials, the primary efficacy and endpoint was a sustained virologic response at 12 weeks regardless of treatment arms used defined as the hepatitis C virus RNA level below than the lower limit of the quantification. So the follow-up. They followed up at 2 weeks, at 4 weeks, and at the last observed treatment. After the study, the patients were to report back for the follow-up at 4 weeks and at 12 weeks post-treatment. And any patients showing a virologic breakthrough or relapse despite therapy was to assay for the mutant variant drug during therapy, at the end of therapy, at 12-week post-therapy. Duration: 12-week treatment for sofbuspivir plus PEG plus ribavirin in the Neutrino study, sofbuspivir and ribavirin plus 12-week in the FISION study, and 24-week treatment of PEG and ribavirin for comparison in the FISION study. Arms: sofbuspivir plus PEG plus ribavirin for 12-week for the Neutrino study, and sofbuspivir ribavirin for 12-week versus the PEG and ribavirin for 24 weeks in the FISION study. Statistical analysis. In the Neutrino study, we determined that the enrollment of 300 patients with hepatitis C virus genotype 1, 4, 5, or 6 infections would provide a power of 90% to show a rate of sustained virologic response with sofbuspivir regimen that was higher than 60%. A calculated control rate based on previous efficacy after adjustment for the presence of cirrhosis and expected safety benefit. The expectation of high response rate, improved safety, and short treatment duration led to the joint decision with regulatory authorized not to include a current available protease inhibitor regimen as an active control. In the FISION study, we determined that a sample of 250 patients with hepatitis C virus genotype 2 or 3 in each study group would provide a power of more than 95% to establish a non-inferiority of sofpusvivir and ribavirin as compared with PEG interferon with ribavirin. Non-inferiority would be shown in the lower limit of the two-sided confidence interval for the difference for more than 15%. We used two-sided testing at 0.05 level in both studies. Multivariable logistic regression analysis characterizing the relationship between a sustained virologic response and a various prospective demographic and baseline clinical characteristics were performed. In the neutrino study, total of 925 of the 327 patients, which is 90% and 95% confidence interval, with hepatitis C virus genotype 1, 4, 5, and 6 had a sustained virologic response 12 weeks after treatment. Rates of sustained virologic response did not differ greatly according to the hepatitis C virus genotype. 89% of genotype 1 in the United States, 92% genotype 1A, 82% genotype 1B, 96% genotype 4, 100% genotype 5, and also 100% for genotype 6. At 12 weeks, the rates of sustained virologic response for the patients receiving 12 weeks of sofpusvivir ribavirin and those receiving 24 weeks of PEG and ribavirin were each 67%. The absolute difference between the two groups or adjustments for stratification factors was 0.3% in favor of sofpusvivir and ribavirin. In the supplemental analysis, we calculated that one-sided p-value associated with the formal test of non-inferiority had a p-value of less than 0.001. There was a high response rate at 12 and 24 weeks after treatment among patients who received sofpusvivir and ribavirin. One of the 166 patients who could be evaluated had a virologic relapse after post-treatment with week 12. That one patient was not resistant to the S282 mutation, which is the only resistant allele that has ever shown resistance to this drug, proving sofpusvivir is still not inferior. Position of each triangle or square indicates the rate of sustained virologic response. 12 weeks after the endpoint at the end of treatment. This is the cystoanalysis graph, which consisted of sofpusvivir and PEG ribavirin and all patients in a single group neutrino study, and which consisted of either PEG and ribavirin or sofpusvivir and ribavirin. Horizontal line represent 95% confidence in the interval. Vertical line represents an overall rate of sustained virologic response for the sofpusvivir group. Arrows indicate the confidence interval that exceeds an x-axis scale. Race and ethnic groups were self-reported. So the primary endpoint. In the two studies, the primary efficacy endpoint was a sustained virologic response, which was defined as a hepatitis C virus RNA level below the lower limit of the quantification at 12 weeks after the end of treatment. For the neutrino study, the two-sided one sample exact test established the primary efficacy endpoint of the superiority of sofpusvivir plus PEG interferon and ribavirin, as compared with an adjusted historical response rate of 60%. The FISION study, sofpusvivir plus ribavirin, was shown to be non-inferiority to the PEG and ribavirin. So, adverse events. Most common side effects with all treatment include anemia and dizziness. Most common adverse effects documented seen more during the study with PEG interferon treatment include flu-like symptoms and fever, which is 16% versus 3% with sofpusvivir, depression, 14% versus only 5% with sofpusvivir, and neutrophil count of 500 to 750 milliliter cubed, which is 12% versus nobody, or 0% with sofpusvivir. Neutrophils count of below 500, 2% versus nobody, or 0% with soft buspirivir. So some strengths of this clinical trial. Most of the patients in the neutrino study had hepatitis 0 genotype 1 at 89%. Prevalence in the USA for hepatitis C genotype 1 is 70%. Therefore, the study closely resembles that most people have here in the USA. The demographic and baseline clinical characteristics were balanced between the two study groups in the fission study. A total of 20% of patients in soft buspirivir had cirrhosis, and a total of 21 of those in the PEG group had cirrhosis. 666 patients with genotype 2 or 3 were essentially screened. 527 underwent randomization, and 499 began treatment. Step-by-step selection procedures was used to identify independent predictors of sustained virologic response. Deep sequencing analysis at post-treatment visits the hepatitis C virus RNA was detected, showed no resistance associated variant to soft buspirivir. Treatment discontinuation and uncommon among patients receiving soft buspirivir regimen, with more seen with PEG regimen. Weaknesses. Cost-effective analysis could have exploded the study even more. The new drug had not studied very long. The one patient showed virologic relapse in the fusion trial, although proven they were not resistant to the S282 allele response. Allele reasoning is still yet to be known and is currently unknown at this time. The study purpose was to set efficacy and addition to the polymerase inhibitor soft buspirivir to the regimen used to treat hepatitis C virus. The addition of polymerase inhibitor proved to have a much greater efficacy, took less time, and had less side effects than without. In the two multi-center trials, soft buspirivir improved the therapeutic response, reducing hepatitis viral load when added to the PEG ribavirin therapy, and showed less adverse effects compared with PEG interferon therapy alone. No S282 mutation were observed in any patient with soft buspirivir, therefore may be a blockbuster in treatment of hepatitis C therapy. However, not everyone in the study had sustained virologic response, and the reason remains unclear. But the lack of documented resistance to no S282 mutations provides the rationale for studying retreatment with soft buspirivir containing regimen in the future for patients with hepatitis C virus. Soft buspirivir has the potential to be a blockbuster drug based off the study. Keep an eye on soft buspirivir and the combination required therapy for hepatitis C. Thank you.